Good evening, respected chairpersons, expert panel members, and all the delegates of India Live. Before I start, let me express my heartfelt thanks to all the course directors of India Live. Really, we are very, very happy to assist with India Live, and I convey my best wishes to all delegates and all the organizers of India Live from Kim Sunshine Heart Institute, Begumpet, Hyderabad. Today we are going to show a complex left main bifurcation using orbital atherectomy under intravascular ultrasound guidance. First, let me narrate the history of the patient details. That is 75-year-old male, known hypertensive, diabetic, with a history of PCI2, LAD, L6 and RCA in 2012 and 2018. He presented to us with the recent onset of unstable angina. Echo showed normal LV function and his creatinine value 0.9 and renal blood sugar 157. You can see the angiogram showing a significant disease of the diffuse long segment lesion of the LAD and L6 disease, and you can see the right coronary total occlusion. 4 days prior to the procedure, what we thought, we'll do the right coronary angioplasty stenting to give a good backup to the left system. So we used right radial approach, AL1 catheter, that is 7 French guiding catheter, using the slender sheath. So with this note, let me have a discussion. Over to Dr. Shailendra Singh.
Come with significant angina and his drop-I was elevated. So we admitted him and did the angiogram. The plan would be to just open the RCA first and then go for LM to LCX stenting. That would be the plan. The history is quite classical that the patient has unstable angina. So 2018 was his last angioplasty, and now 2023, 5 years later, he has come with significant unstable angina and drop-I elevation.
Pierre, you want to discuss anything?
I would like to know that stenting in the presence of this near total or subtotal occlusion of RCA, stenting of the circumflex, how challenging it would be?
In this case, though there is a very short segment, almost near total occlusion of the ostial, distally, if you see the retrogradely filling nicely PDA, PLV. So what we expected mostly stent restenosis, and at the same time LAD appears to be not that significant. When LAD is not that significant, the patency of the graft is doubtful. So the one option, you can do the functional assessment of the LAD, L6, and if the LAD is significant, then CABG is the ideal option.
What is the kind of stent plaque modification is necessary for a majority of patients with LCX ostial lesion, because it is very important to use, even if it is non-calcified, you have to use a cutting balloon. If it is calcified, then you may require some additional plaque modification like IVL or ROTA or anything of like in those choice. But if there is, what is the stent that would be ideal? I'd like to ask Dr. Sridhar.
Any stent with a good radial strength, and when you are doing the left main bifurcation, the cell size should be good. When the cell size is good, crossing the side branch. Now, of course, all the latest stents are having a more than 3 plus the cell size. So that is also very important. And how many links are also important. If the more the links, then one advantage, more the links, it will give the more radial support. But at the same time, most links across the L6 ostium, then again the stent ostium across the L6 ostium, there may be tissue growth.
Most important thing is the presence of radial strength. Apart from that, I feel the second most important thing is usually there is a disparity, there is a mismatch between the left main and the LAD or L6. So you have to choose a stent where it can be expanded.
Looking at the calcific this thing and 75-year-old male, what would be the best plaque modification therapy and safe to avoid complication in such a difficult case?
What kind of plaque modification device you are going to choose is very, very important, essential here. I don't want to use ROTA for this patient. Why? Because very easy to do it. LM to LAD and L6 you can do it. But here distal LAD is deceased. So when debris goes, and most of the time debris can cause, when in the presence of distal LAD disease, that can lead to slow flow, no flow phenomena. Of course, here the advantage, we have opened the right coronary. So it's very safe only. but I anticipate slow flow, no flow phenomena in the presence of distal LED disease, and relatively no flow phenomena, slow flow is less with orbital atherectomy, because the microparticle it generates is only 2 microns versus 7 to 10 microns with a rota. And another one is if the deep cap, the left main area is big, it's a 4.5. So even if you use the 2 burr also, that may not cause adequate plaque modification, particularly in the presence of deep calcium. Okay, only superficial calcium, if you shave it, that's fine. Now we are saying only plaque modification, subsequently modify it, that's enough. Now we are starting the live case demonstration. You can see the left main, there is a distal tapering compared to the proximal. Distal, there is a definite significant block is there, and if you see the LCX is very tight, osteoproximal lesion, very tight lesion, and LED also there is a considerable plaque burden. Now you see the just after septal there is significant lesion, and this entire vessel is severely calcified. You can see before injecting the contrast, the calcium is seen on both sides of the vessel wall and more than 25 mm. You see the entire LED is calcified before injection, proximal mid. So long segment calcified lesion, but beyond stent and proximally also we are able to see the calcium plaque, and LCX ostium also calcified. So now we will assess the IVUS assessment of the LCX first, then we will see the entire LED, and really LED requires or not. Angiographical I feel he requires a 2-stent technique. We can see the distal LED as significantly diseased and diffuse long segment lesion of the proximal to mid. Relatively distal LED appears to be fine, but at the apex again there is significant disease. You see the when you are passing the IVUS, are we able to cross with IVUS catheter? That is very important. If we are unable to cross with, you have to use the rota or orbital atherectomy like uncrossable lesion. Distally, there is no significant block. You can see the trilayer structure, you can see luminal area very good. There is no significant plaque burden. This is from the distal LCX. We are able to see borders very clearly, very good IVUS images. You can see the trilayer, no plaque burden distally. See trilayer structure, no plaque, and we are coming proximally. Here some plaque is appearing. You can see the small branch, some calcium is there. You can see the eccentric calcium, almost 270 degree, thick calcium, luminal area, diameter is only 2 mm. This is the previous stented segment. There is a calcium, LCX ostium, very severe plaque. You see the very tight, severe calcium, that is the LED. You can see the wire in the LED. So this is the LCX ostium. LCX ostium is severely calcified. You can see almost 270 degrees. Eccentric plaque, and you can see this is the eccentric plaque. Now I am pulling it to the left main. Left main also calcification is there. Almost a 300 degree calcium is there. Though distal LMC are diseased, but more importantly LCX ostium is significant calcium, and previously stented segment also diseased, and slightly distal to the stent also there is some disease. Now we will acquire the IVUS study of the LED. See, this is a uncrossable lesion only. So we are unable to cross that mid LED lesion beyond that segment. You see there is severe calcium, almost 360 degrees, thick calcium. You see severe plaque burden, even LED ostium also severely calcified, that is L6. Now distal left main. Distal left main tapered, though L6 is showing the plaque, but appears to be stent is not that tight, but ostial L6 definitely severe disease, and LED that after septal we are unable to cross that segment with IVUS catheter. That means it's a very and a severe 360 degrees calcium and a very thick calcium. So we use the orbital atherectomy for this case. So you can see here angiogram so deceptive. In this view it is not appears to be that tight, but another it is tight. What I suspected while passing the 1.5 balloon also we were unable to, there was difficulty in crossing. So orbital will do, then subsequently if needed NC balloon dilatation, we will acquire the IVUS, then we will go with the 2-stent technique. Diffuse disease of the LED and L6. So LED uncrossable lesion, that is the reason we are not going ahead with the IVL. Initial strategy was to go with IVL, plaque modification. So when we are unable to cross with IVUS catheters, the best modality, either you can go with a rota or orbital. Here why we are preferring the orbital, because the thick calcium is there and very severe calcium, we wanted to use both LCX and LAD, and distal LAD diffuse disease. When the distal LAD diffuse disease, we anticipate some slow flow, no flow. So that is the reason the slow flow, no flow is slightly less with the orbital atherectomy, and it cuts the, even LCX ostium is eccentric calcium. It cuts the LCX eccentric calcium more effectively. That is the reason we are opting for orbital atherectomy. So particle generation is very small, 2 microns versus 7 to 10 microns, and during cutting there is a continuous forward flow in orbital, whereas in rota there will not be any forward flow. When you are using the orbital atherectomy, you can do forward cutting and backward cutting. So whereas rota only forward cutting. Sometimes what happens, it may suddenly jump beyond the lesion and it may cause the burr entrapment, dislodgement, stall burr. So, but at the same time, orbital atherectomy, forward and backward cutting, even if you cross the tightest lesion, you can pull and do the backward cutting. That is the advantage. So, backward cutting, forward cutting, maintains the forward flow, and slow flow, no flow is less likely, and larger the vessel, the effectiveness of the orbital atherectomy much more compared to rotal. So, like it can ablate the even left main also more, 2.5 to 4 vessel, it can more effectively do the plaque modification. Suppose if you are using the LAD rota, then LMCA you may require bigger burr, 2 Here you can use single burr, increase the speed. 80,000 versus 1,20,000. So you can larger vessel, when proximally you can see the tapered, proximally much bigger, distally. So that is the reason we wanted to choose the orbital atherectomy in this case. One is eccentric calcium, one is the asymmetry of the lesion, tapered vessel, another one is slow flow, no flow due to distal disease, and more effective ablation. With Viper wire using the microcatheter we placed too distally. Why? Because there was a difficulty in placing the wire. That is the reason we kept the distal as possible. Now this is the orbital atherectomy crown. You see, this is eccentrically mounted. This is the elliptical shaped crown, whereas a rota, it will have a bullet shape. The proximal half is studded with a diamond. This is centripetal. This moves along the periphery of the vessel circumference. Now you can see the very clearly that burr movement. Now this is the, when you want to start the orbital atherectomy, turn this angle and press it, move it. Once you press it and locking and unlocking of the burr. This is the 80,000. This is 1,20,000 speed. So high speed ablation if you want, 1,20,000. This is 80,000 revolutions per minute. So this is the glide mode. While placing the orbital atherectomy inside the catheter, you can put the dynaglide. Orbital atherectomy is at the left main. So now we will start, we have to remove the second wire. While doing orbital atherectomy, don't use the, because it can cut the second wire. That is the advantage of using IVL. When you are using the IVL, you can keep the side branch wire. While doing rota and orbital atherectomy, you have to remove the side branch. You have to go very slowly, 1 to 3 mm at a time, forward and backward. Now I am doing only proximal LAD and distal LMCA. This is the tightest area. ECG, pressure, everything is fine. So whenever you do the plaque modification, post plaque modification, do the imaging. If you see the fractures, if there is a gain in the luminal area, or if you see some dissections, and also you see the thickness of the calcium. If the calcium thickness less than 0.5 mm and gain in the luminal area and fractures. Otherwise, you can, suppose if still inadequate, you can use the cutting balloon or angiosculp or high pressure NC. Again repeat IVUS, whether fractures are there or not. If fractures are there, means it is adequate modification. Then you can go ahead with the stenting. See, it's flowing well. That's fine, I think. Now reasonably good. We'll go with the 1,20,000, 2 runs. Then after that, distal if needed, we'll try to do with the small balloon dilatations. Now we are going ahead with the 120. Now we did the orbital atherectomy of the proximal to almost a distal LAD, and now we are taking the IVUS images. You can see now I am pulling manually. Now you can see there is eccentric lesion, calcium you can see very clearly. You can see the fracture there. Here also you can see the fracture. There is a definite luminal gain is also there. So those are the fractures. You can see the discontinuity. Even LED also now looking much bigger. You can see now compared to earlier. I think this is adequate plaque modification, no need to do anything. We finished the orbital atherectomy of the LED. Now we are proceeding with the orbital atherectomy, the distal left main and LCX. We did the further plaque modification with angioscope, LCX ostium and LED nicely yielded with 3 mm NC balloon 3 into 15. So proximal to distal we did the further dilatations. Now we are planning to place the LED stent, that is 2.75 into 48 mm Zeiss. See, without guide liner we are unable to place it. Now I am advancing this one. Now I am pulling the guide liner. Deflate. Deflate. Go ahead. You see, nicely expanding. 14, 15. Yeah, deflate. That's enough. Now we are placing a stent in the LCX, covering the proximal edge of the previous stent. This is about 3.5 into 15 mm. We are keeping one more balloon in the LM to LED because once we implant the stent, we wanted to crush adequately. Implant. Please. Do it. Deflate. Always ostium should be adequately dilated. Before crushing, ostium of the LCX stent should be opened perfectly. Deflate. Yeah. I am removing the wire and balloon both. Deflated. Ready? Inject. Good. 18. 18, 20. Deflate. LED, let us see distally. Ready? Good. Flowing very nicely. Now we are doing the first kissing. After first initially we will dilate the struts with the 1.5 balloon. We will take 3.5 balloon, one into the LED, one into the LCX. And the crushing was done with 3.5 balloon. Now we are placing a stent from LM to LED. We are using the technique of decay crush. Go ahead. Go ahead. That's fine. Go ahead. Yes. 4.5 enough. Then the part was performed. So part we used 4.5 to 6 mm. Stent is a good landing zone. Stent nicely expanded. Beautifully expanded. Area is also good. Now I am coming to the ostium of the LED. LED ostium also nicely expanded. This is LM. See, LM almost 1, 2, 3, 4. That's fine. There is no proximal dissection. Eccentric, but it is more than 4. 5.27. Good. That's show me the distal LED once. Show me the last view. We wanted to maintain the patency of the LED. So that is the reason 1.5 up to 18. That will come to up to 2 mm. Then we did the 2 mm balloon DEB inflations. That is 1 minute inflations. 6 atmospheres twice. So ideally the DEB as of now strongly recommended to side branches and diffuse long lesions, distal lesions and ISR lesions. So if the ISR is there, then fibrotic lesion, cutting balloon or plaque modification, use the DEB. Particularly when there is a multiple layers of stents, and the results are much more superior compared to this. And the distal LED lesion, diffuse lesion, diffuse long lesion. So here we thought of giving a additional benefit by giving a DEB application. Wonderful result. You see the LED, distal LED, nicely flowing, entire disease, so many septals, so many diagonals, all branches are flowing well. Even distal LED with DEB, extremely good result. See, stent expansion is very good with orbital atherectomy. That is the advantage of plaque modification. See, now LCX also flowing very well. The advantage of the radial, the bleeding complications are less. He is obese man and severe disease, right coronary, CTO, that also we did through the right radial approach. And LCX, LMCA, very diffuse disease. We did the plaque modification using the orbital atherectomy. LED, LM to LED, we did the plaque modification using orbital. Then LCX also we did the plaque modification orbital. We performed the imaging through the using the IVUS. And while placing LED also, LED stent, we face a difficulty. We use the guide liner. So all complex procedures can be performed through the radial approach. So a left main decay crush we did with plaque modification, and see bleeding is less if they're femoral and like a 75-year-old obesity is there. The maximum rival study, matrix study, if you see, the maximum complication rate is due to the access complications. So that's the reason MACE rate is much more in a femoral versus radial. I think this is a wonderful case. Thank you all of you for joining. We wanted to showcase the IVUS guided plaque modification of the LMCA using the decay crush stenting. Introduce my colleagues, wonderful colleagues, Dr. Kavya and Dr. Rajaram and Vasu and Venu, technicians. So with this note, I hope we have showed a very nice case, and really we are very, very thankful to all the chairpersons, moderators and delegates of the India Live participants for participating this live inbox case session. And I am also thankful once again to all the course directors of India Live. Thank you one and all. On behalf of Kim Sunshine Heart Institute, this is your Dr. Sridhar Kasturi.